Ready? If one doesn't want, I have taken attendance. I don't have any problem. Once I will start, everyone with me. Okay, the first question for acute, as I will start, what are the pathological changes of acute inflammation? Everyone, yes, tell me what are they? Vasodilation,
Increased permeability,
and
neutrophils.
Now, what's the other name of acute inflammation? Exudative. Why? Because I have this one.
Fluid.
All right. What are the causes of acute inflammation?
Microbial infection, chemical factors,
Chemicals.
hypersensitivity.
Now, what are the outcome?
Complete resolution.
Fibrosis.
Progress to
Chronic
chronic inflammation. This is general. Yes, what is acute inflammation? Now, the most important part starts with these questions. What are the clinical subtypes of acute inflammation? So I will start. What is serous? Tell me. Accumulation of serous fluid. Yes, I have two areas. One, skin, and the second one, in body cavities. It is called effused. What are the characteristics of this cell, of this serous?
Bacteria.
Bacterial, no bacteria, acellular, nearly acellular. Okay, it's very important because I will ask what's the difference between serous and purulent. Okay, so when I will put this picture, what is this? Number one. Yes. Please wait. I will put the second one and one. Yes. So you tell me what is this? This is a skin blister clinically. Microscopically, there is one separation in the dermo-epidermal junction and filled with fluid that is serous fluid. Yes? This fluid, this is what you will answer, is acellular and it doesn't contain bacteria. Plus, I have acute inflammation, so I will have all the changes of acute inflammation in the dermis. Okay, which are neutrophils, vasodilation, increased permeability. Okay, any questions? Then I can ask, where do I see another, give me another example of serous, you tell me cavities, it is called effuse. Okay? Alright, now, before I move to the purulent, please remember what is this appendix. Why? Because I want you to see the mucosa. I want you to see the layers, which are submucosa. I have lymphoid follicles, and then I have muscularis and serosa. What's the hallmark of acute appendicitis? Tell me. What I will see. It's acute. It's purulent. So what I will see?
Pus.
But what is it? Neutrophils in all layers. Please remember this. Okay? It's not only in mucosa. I must see neutrophilic infiltration in all layers. Now, I will put the picture, which is the second one, and tell me what do you see. Stop. This is, you tell me, purulent. What does it mean, purulent? Contains pus. What is it? Accumulation of neutrophils. And this fluid is cellular because it contains large numbers of neutrophils and it contains bacteria. Okay? Now, start. What do you see? This is purulent exudate in the central or abscess. What about mucosa? What I will see? I have acute. In any, what do I see?
Ulcer.
In any epithelial layer when I have acute inflammations?
Ulcer.
What is ulcer? Loss of epithelium. What I will see in all layers? I will see neutrophils infiltration, and I will see vasodilation. I will see increased permeability. Yes. Agree, everyone? Okay. What do I see?
Epidermis.
Epithelium. So what do I see?
Epidermis, epithelium.
That's the second picture. I will see ulcer. This is the pus, okay? And then the third picture will come where you will see neutrophilic infiltration in all layers. Here again, where I am, mucosa, ulceration. This is all the layers with the muscularis, and I have infiltration of neutrophils. Okay?
Neutral.
So,
Ionic.
if I will ask, what is purulent inflammation?
Pus.
Pus. What is pus?
Neutrophils.
Cell debris, dead bacteria,
Necrotic
edema fluid.
structures.
Yes? Always. Give me example. This is acute appendicitis. In acute appendicitis, a star. In the central part, what do I have? Abscess. I have epithelial lining and I have acute inflammation. So what will be to this epithelium?
Ulcer.
And I will see all layers infiltrated with neutrophils, vasodilation, and edema. Okay, that's the complete answer I want. Number 3, what is this?
Fibrin.
Fibrils. What does it mean, fibrils?
Fibrin network.
Which means I have increased permeability for fibrin to go out of the vascular walls, and I will see it in the form of what?
Network.
Eosinophilic hyaline meshwork.
Meshwork.
Now, this meshwork, where do I see? Give me examples.
Lab.
Body cavities. The main thing is body cavities. Because when it is linked with ulcer, I will put a picture pseudomembranes. Okay? This is in body cavities. Okay, just meshwork of eosinophils. And I will see also in the chronic ulcer, when I will explain to you now, I will see meshwork of eosinophil with cellular debris at that time. But just neutrophils, I see mainly fibrinous exudate in body cavities. Now, I start like this. When I put a picture, you see what is this? Colon. Everyone agrees? Colon with goblet cells a little bit. Look at the upper part. What happens in
Ulcer. Ulcer.
Ulcer, measles, plus fibrinous.
Pseudomembranes.
What do I call it?
Pseudomembrane.
Why it is pseudo? Because it gives the impression of membrane,
But
it is
it's not.
membrane. It is composed of ulceration plus fibrinous exudate. Okay? Give me another example.
Larynx. Diphtheria.
Larynx diphtheria. Okay? Let's go and I will come back again to you. Okay? Diphtheria, pseudomembranous.
Colitis.
Okay? This is a very good one. You see colon necrosis. You don't see nucleus. Remember? Non-nucleus necrosis with eosinophilic meshwork together, pseudomembranes. Look at here, colon is gone. Okay? Any questions? Now I will explain this. Please pay attention, this is important. Now, I will explain the acute ulcer and the chronic ulcer. Yeah? What is ulcer? We saw in every acute inflammation, I have the superficial layer. If it is lined with epithelium, there is a great chance for this epithelium to have ulcerated small fossils. Yes? This is in acute. What I will see superficial erosions, loss of epithelium with neutrophils, and I will see fibrinous. When they are so much, I will see pseudomembranous. Okay? Now, if the problem is chronic, what does it mean? It means that it started as acute ulcer, but it didn't resolve, so I am walking where? Toward chronic ulcer. Yes? Now, my question, I have said several times, and I want you to remember now, my question, if I have acute ulcer that is transformed to chronic ulcer, and the body will try to close this ulcer, what I will see? Which tissue? Granulation tissue. Okay? Everyone agrees? So, the ulcer that is chronic, like here, yes, in gastric ulcers, we have stress ulcers that are superficial erosions, the one that I told you, okay? They can resolve with a small medication, etc. But once it is turned into chronic, or if I have Helicobacter pylori, you studied this in, yes, and I will see chronic ulcers, okay? Which means that the disease will take time and it will transform into chronic. What I will see grossly, tell me, what do you see? Explain.
Folding.
Ulcer, and what happens to the folds? They are radiating from the central part of the ulcer, and they have smooth surfaces. Why I'm telling this? Because next time I will start with malignant ulcer. Okay? Something that is transformed into malignant proliferation. Now I don't have malignant. I am still in chronic ulcer. How I will see grossly? This is your job. Yes? You will do endoscopy and you will see this picture. Of course, you will send biopsy to us because at the end pathology decides, but you will have direction, 70-80% direction. This is central ulcer that is low. Look at it. It is low in level because I will put the picture. Yes? And I will see the folds radiating from this central ulcer, and the folds have smooth covering. They are not necrotic, friable material that I will see in malignancy. Now, this is another one. Yeah? Always look. It is lower, and look at the edges, they are radiating. Now, I will put the micro and tell me what do you see. According to the chronic. Remember the chronic, according to the picture, gross. What do you see? This is the central ulcer, and these are the folds that will radiate. Yes? Everyone could imagine? Now, the radiating one are normal. Yes? We saw them. Normal, smooth surface, radiating. The problem is here in the base. Now, first notice that it's so deep that it is, where it is?
All the layers.
In the muscular layer. Yes? The mucosa always done, and even part of it. It's very deep ulcer. It's not superficial erosion only mucosa. It's by time, it's going and going and going, and I have deep ulcer. Now let's see the base of this ulcer. First, I will start with the diagram, and then you will sew. Now you told me the body will try to cover this ulcer with granulation tissue. How I will see granulation tissue? What's the hallmark of granulation tissue?
Capillaries.
Yes? Many capillaries. Once I will see area with many capillary formations and inflammatory cells, this is granulation tissue. Now what I will see up. Now this was started with necrosis, acute, etc. So what I will see, necrotic debris. Yes, this is how it started, where it will go the debris. Necrotic debris. Every necrosis will try to bring what? Neutrophils. So necrotic debris and neutrophil infiltration, this is from the beginning. But once the body starts to try to will cover, I will see granulation tissue formation, which is many capillaries. Now what I will see at the base?
Fibrosis.
What's the function of granulation
Fibrosis.
tissue? Fibrosis. Okay, so when I will tell you what are the layers of chronic ulcer, start. Necrotic debris, neutrophils, granulation tissue, fibrosis. Okay, everyone got it? If I have acute, like the appendicitis that I showed, let's go back, you will see only neutrophilic debris, bacteria, like the abscess. Okay, you will not see formation of granulation tissue. Once granulation tissue has started, I have chronic process, I have the repair that has started. To how much it can end the problem, we don't know, it depends. But the granulation tissue is that the repair has already started. Okay, so just I will put it the appendicitis and look at it and tell me, what do you see? Do you see any capillaries? No, just ulcer. And just neutrophilic infiltrate. This is acute purulent. And let's come to the gastric mucosa. Now, this is the micro. Look at these debris, yeah, with neutrophils. Zone of granulation tissue, how do I know?
Capillaries.
Zone of fibrosis, fibroblast, elongated, and this is the muscularis mucosa where it arrived. Okay? Look at this new blood formations with inflammation cells. This is zone of granulation tissue. Okay. Any questions? So I will put the picture gross. How it will be in the test or exam. Yes? And then I will tell you what is this. You already tell me the ulcer. Now tell me the layers. Yes? You start. Necrotic with neutrophils, fibrous exudate also I can tell, okay? Zone of granulation tissue, zone of fibrosis and muscularis propria, okay? This can be fibrinous with necrosis, with neutrophils, everything admixed in the upper part. That's the remnants of the acute inflammation. Okay? Any questions? Shall I continue? Okay? Everyone knows how to answer? Go. Tell me, what is this?
Lateral.
What did you say? Catarrh. What does it mean? It's acute inflammation with
Excess
of
mucus.
mucin production. What kind of mucin this is?
Mucoid.
Everyone answers. Yes? Give me example. Acute rhinitis, acute bronchitis. Okay? When there is excess of mucin production. So I will deal with any mucosa that has mucinous glands. Okay? So I see acute inflammation, vasodilation, neutrophils, plus excess mucin production. The mucin, I call it mucoid because it's of epithelial origin. Tell me, what is this?
Hemorrhage.
What do I see?
Hemorrhage.
Hemorrhage. Many hemorrhage with acute inflammation. So you just call it any acute inflammation, which means that you see neutrophils, vasodilation, edema, etc. When you see excess red blood cells that are extravasated outside capillaries, or you see dilated capillaries also, it is hemorrhagic inflammation. And even with color, you see this dark color, this is due to hemorrhage. Now, I will start with chronic inflammation. Yes? Tell me, what is the hallmark of chronic inflammation?
Proliferation.
It is proliferative, okay? Because everything is proliferation. Now, what are the causes? What is it? Number one, proliferation of mononuclear inflammatory cells. Number two,
Tissue destruction.
tissue destruction. Number
Repair.
three, repair, which means proliferation of fibroblasts and granulation tissue if I have ulcer. Okay, so everything is proliferating. Tell me the causes of chronic inflammation.
Persistent infection.
Infection, persistent infection.
Toxic.
Prolonged exposure to toxic. And number three,
Autoimmune.
autoimmune. Remembered? Now, what are the histological types that I can see? How it represents interstitial. Histologically, the architecture.
Polyp.
Okay?
Polyp.
It can be interstitial, in between, diffuse. Okay, you can tell me diffuse or interstitial. Number two, it
Polyp.
forms
Polyp.
polyps. Number three,
Surrounded
granulomas
parasites.
and foreign body granulomas, epithelioid and foreign body granulomas. Again, this is important. How I see chronic inflammation, architecture, how it can be. Number one, interstitial or diffuse. Number two,
Polyp.
polyps. Number three,
Granuloma.
granuloma, epithelioid and foreign body type. This is important. Yes? Now, what is the outcome of chronic inflammation?
Sclerosis.
Fibrosis. Sclerosis means that high iron deposition in the strong. And this is sclerosis. It's the fibrosis with hyaline deposition, hyaline degeneration. Sorry. Number 3, cirrhosis. We will see, and
Cirrhosis.
it is, of course, I have insufficiency of the organ. Because we studied, and I will repeat it again, because regeneration alone is very rare. There is always fibrosis accompanying, and fibrosis will not return the complete function of the organ. Okay? Now, when I will start the pictures, number 1, where are we?
Kidney.
Kidney. Yes? What do you think the cells are? This
Intestine.
is second picture. To tell me what are the cells?
Interstitial.
What are the cells?
Macrophage.
Lymphocytes. Small dark. Remember. That's a start. This is histology. Neutrophils bilobed. Yes? Remembered? Yes? Eosinophils bilobed, but with eosinophilic granules. Tell me, where do we see eosinophils?
Allergy.
Parasite and allergy.
Allergy.
Where do I see mast cells? Again,
Allergy.
hypersensitivity reactions. Now these are neutrophils. When I have only this dark color, what is it?
Pycnotic.
Lymphocytes. Yes? When I see the nucleus one
Plasma
side and
cells.
this is the
Plasma cells.
cells. Histiocytes, just like
Elongated.
and they don't have distinct cytoplasmic borders. Okay? Now the epithelioid we will speak about in the granulomas. But this is in general. So when you see this small dark, what are they?
Lymphocytes.
So what do I have? Chronic inflammation. Now look at this chronic inflammation. Can you tell me the type? Diffuse.
Diffused interstitial.
In between. Now what it is written extra, I don't want it here. This year I want you to see this chronic inflammation because in acute pyelonephritis, this is pyelonephritis. And we will deal with acute and chronic pyelonephritis a lot because it's especially in women, it's very common. Acute pyelonephritis with fever, with dysuria, with pain at urination, okay? You will deal with it. It is acute. When it is acute, you will see neutrophils diffuse, and you will see neutrophils inside the tubules, plus I will see vasodilation edema. What I know, okay? Nothing specific. What I know in acute inflammation. Now, if this chronic, the picture is specific, but next year. For me, the chronic now, this year, you see only diffuse mononuclear inflammatory cells. Okay? Any questions? So when I will put this picture, I will tell you what inflammation is this. This is number 1, for you to know that this is kidney, and this is number 2, to see that the inflammation is mononuclear and it is diffuse. Agree? Oh. Now, this is what? Polypoid, okay? You see?
Elevation.
Polypoid elevation. What is polyp?
Elevation of the
Elevation
mucous
from the mucosa. Okay, it can be inflammatory, tumorous, okay, viral infection, whatever it is. It is just elevation. How do I know this is chronic? Inflammation, look at it. Dense inflammation in lamina propria. Okay? And I will see some ulcerations, erosions, because it's outside, so it can be affected the surface epithelium a lot, and I can see secondary inflammation. Now, I will just, for information, this is chronic, but at the very up of it, when you go close in sometimes, you will see neutrophils. What does it mean? It means that I have secondary inflammation, acute up, but in general, it is chronic inflammation. Okay? Any neutrophils you see, you tell me acute. But the predominant, it is mononuclear, except this up. So I have chronic inflammation with the periphery with secondary infection. Okay, it happens in gallbladder, in these polyps, inflammatory polyps of gastrointestinal, because they are elevated, so they are prone for secondary infection. Okay, any questions? So this picture, what is it? Inflammatory polyp, elevated. Okay, this is the level. It is elevated. You see some erosions. Okay, some fibrinous. This is secondary infection. But in general, it is chronic mononuclear inflammatory infiltrate. This is the picture. What do you see? Mononuclear cells. I will put two. Okay? This is the first impression. What I'm doing. And this is the second one. Okay? Any questions? What are the cells? In a specific, tell me.
Plasma cells. Lymphocytes.
What do I have? Another one. Which inflammation? Chronic or acute?
Chronic.
Okay, till here. So all the pictures are for you to see how it is interstitial, diffuse. Except this one, it is elevated, so I call it polypoid. But this, again, I put something like this, just chronic inflammation. The cells, plasma cells,
Lymphocytes.
This is again chronic inflammation. Now I will start with granulomas. Yes, tell me, everyone with me, what is granuloma?
Aggregation of the epithelioid cell.
Accumulation of
Epithelioid cells.
epithelioid macrophages. What do you understand from this? That the base is macrophage. Yes? Why do I have this epithelioid? Because they change their character, because they see that it's not enough to get over the problem. So they change their character. They start secreting activity and they become like epithelial cells elongated. Okay? So that's granuloma. What is granuloma? Accumulation of epithelioid macrophages. This what is acute, what is chronic, what is granuloma? You don't answer, I don't continue. Everyone, this is the number one question. This is the entrance to the test. Okay? You have entrance code, you enter. You don't have this. I don't continue. Okay? So everyone. What is acute? What is chronic? What is granuloma? This is the code. Then I start. Now, what are the cells of granuloma? Number one. Start with macrophages. Because they are epithelioid. Number two.
Epithelioid.
Number three.
Multinucleated
cells. What are these? They are epithelioid cells
In
or
one.
histiocytes in foreign accumulated because there is a strength in unity. Yeah. What are the types?
Foreign word is Langhans.
Langhans. Okay. Tell me classification of granuloma according to
Morphology.
cause. Etiology. Infectious, non-infectious, unknown. According to pathogenesis. Okay. Now, tell me according to morphology. That's important.
Mature, immature.
Now, what does it mean mature?
Epithelioid.
What does it mean immature?
Histiocytic.
Okay, till here. Now, I will start. If I will put a picture like this. Yes? Where are we?
Lung. Pindal.
What happens to this lung?
Granuloma.
Before granuloma, what did you see? Chronic inflammation. How can you describe this? Do you see destructive? Because I don't see parenchyma in these areas. Yes, I see destruction of normal architecture. What do I see? I see nodular aggregates of eosinophilic color. That's what you see from the beginning. That's what will be in your exams. Okay? You see lung, you see areas where you don't see any parenchyma. You see instead well defined, because epithelioid granulomas are well defined. Remember, histiocytic granulomas are not well defined. You catch them from multinucleated giant cells. Okay? But the epithelioid ones are well defined, which means that you look, you see well defined nodular structures. Now, they are eosinophilic, so you start thinking of granuloma. You need second one. This is the second. So it confirms the diagnosis. What is the diagnosis? Epithelioid granuloma. That's what I want. Non-caseating epithelioid granuloma. Okay, you don't see caseation, You just say accumulation of epithelioid surrounded with lymphocytes.
Lymphocytes.
You just tell me epithelioid, non-caseating granuloma. You don't even know this is sarcoidal because these lymphocytes may be in lymph nodes. Okay, you don't know anything. You just tell me this is non-caseating epithelioid granuloma. Okay? Now, another one. What is this? Where are you?
Kidney.
What happens in these areas? Again, destruction. What do I see? Well-defined eosinophilic aggregates of epithelioid cells. So it is epithelioid granuloma. Point. Non-caseating. I don't see caseation. Remember, caseating is, what is caseatic necrosis? Remember. It's with your eyes, cheese, white, friable. Microscopically, it will be granular. Why I am telling this? Because I want you to differentiate between caseous necrosis and coagulative necrosis. In coagulative, I will see the shadows. But in caseous granular material, acellular. Okay? Because it's like cheese. Friable white cheese, how it will be? It will be friable eosinophilic material. Okay? So, I don't see, I see just granulomas, non-caseatic epithelioid granulomas in kidney. That's the answer. Now I come to the first one, that is tuberculosis. Yeah? This is theory question, but please study it with this because it's easy. Tell me, what is this tuberculoid granuloma?
Central
First, you
located.
tell me it is epithelioid. What's the family? What's the big one? Epithelioid. Number 2.
Necrosis.
Caseating. Composed of start. Central caseous. Surrounded by epithelioid, surrounded by lymphocytes,
and
I see multinucleated giant cells of which type?
Langhans.
Langhans. That's the answer. This is the theory question. Okay? Imagine the diagram and answer it. Okay? Now I will put micro. What do you see? Now you can tell. What is this?
Necrosis.
Caseous, epithelioid,
Lymphocytes.
Langhans. So this is tuberculoid granuloma. Remember, just you don't write tuberculosis. It needs confirmation yet. But for us as pathologists, this is tuberculoid granuloma. I can see it in tuberculosis. Give me examples. Where? Leprosy and syphilis. I will tell you, we did in practical. What's the difference between tuberculoid and syphilis? Tell me. Central capillaries, arteries in the syphilis, and what are predominant cells of the mononuclear cells that surround it?
Lymphocytes.
Plasma cells. Okay, surrounding area, I will see many plasma cells. Okay, that's hallmark. That's important for diagnosis of syphilis. Of course, I need blood tests at the end. Okay, I will write tuberculoid granuloma compatible with syphilis. Okay, so where I am? Lung. What's the diagnosis? Easy. No. Caseating. Tuberculoid granuloma.
Multinuclear.
And remember, in use tests or exams, you may see many tuberculoid granulomas. Not all of them can have caseous necrosis, but if you see caseous necrosis in one, this is enough for you to write tuberculoid granuloma. Okay, this is remember in future. Now, where I am?
Lungs.
Lung. What happens? Caseating granuloma, Langhans, epithelioid. Look at this is non-caseating. That's why I say this is non, this is caseating. But enough for me to give the final diagnosis. This is gross. Yeah? This is white, enlarged lymph node, yellowish white, cheese-like necrotic areas. This is tuberculous lymphadenitis. This is lymph node. What's happened? What do you see?
Swollen.
This is the same one that was growth. What do you see?
Swollen lymph nodes.
First, destruction. Do you see normal lymph node architecture? No. What do you see instead?
Okay.
Eosinophilic nodules. Now, sometimes these small nodules can unite together, and I will have something like this, a very big area. Okay? A very big granuloma. So it can be small ones, and sometimes they unite. You see very big granuloma. You can see only one also. Okay? So be cautious. If you see any accumulation of pale color, look carefully. If central caseous necrosis, epithelial with lung cancer, that is tuberculoid granuloma. It can be small or it can be big. Okay, the size is not important. Variable sizes of granulomas you can see in any specimen. Now, this is close. What do you see? One of them. Epithelioid lymphocytes. So what do I have? And lung cancer, look at here. So it's definitely granuloma. Okay? Any questions still here? So remind me before I go to sarcoidosis. What is tuberculoid granuloma?
Centralizes.
Lymphocytes, histiocytes, lymphocyte, epithelioid histiocyte, lymphocyte, multinucleated giant cells of blood. Now look at this sarcoidal. What do you see?
No necrosis.
Unclassiated, very thin ring, so it's naked granuloma. It doesn't have coat of lymphocytes. Okay? Now you can see multinucleated of lung cancer, and sometimes I see asteroid, and sometimes I see
Concordat.
classifications with conchoidal bodies. Okay? But basically, sarcoidosis is non-caseating, naked, which means I will see only small rim of lymphocytes surrounded with fibroblasts. Because remember, granuloma is chronic, and chronic moves to fibrosis. Okay? So you will see various degrees of fibrosis in all granulomas. But to make it easy for you, sarcoidal is usually with fibroblasts instead of these lymphocytes. Okay? It's naked granuloma. So when I will tell you what's the difference between sarcoidal and tuberculoid granuloma, what do you tell me?
Non-caseous.
First, tuberculoid is caseated, sarcoidal is non-caseated. Tuberculoid is surrounded with lymphocytes, while sarcoidal is naked granuloma. In sarcoidosis, I can see not always, I can see asteroid bodies or conchoidal bodies. Okay? What is this? Let's start with, this is granuloma. Yes? You don't see caseation. You don't see much lymphocytes, so it is sarcoidal. This is number one, small. Okay, this is more. So you will see that it is naked because the lymphocytes I see they belong to the lymph nodes. And this is asteroid body. This is Crohn's disease. Again, sarcoidal granuloma. This is again Tulavina propria. It is non-caseating granuloma. Next year, or internal medicine, they ask you what is Crohn. It is chronic inflammation with non-caseating granulomas. Okay? It's a very serious disease. You will study about it a lot in internal, in surgery, okay? But always remember, Crohn has non-caseating granuloma. It is chronic disease. Okay? Now, what do you see?
Non-caseating.
Again, accumulation of epithelial cells, and this stuff, non-caseating naked granuloma. So this is Crohn, and these are the colon lights. Now, when I will see pseudo-tuberculoid, what you will tell me? What do you see in the center? Necrosis.
Neutrophils.
Non-caseating granuloma is
Caseated.
pseudotuberculoid. It's separated granuloma. Remember this word because you know once you listen separated, it means neutrophils. Okay? And if you see any necrosis, it will be coagulative type. So it's separated granuloma. It's not caseated necrosis if you see, but mainly it is neutrophils. Okay? And surrounded with lymphocytes and histiocytes, epithelial type together. Okay? Look at this central neutrophilic abscess, like separated with histiocytes and lymphocytes. Now, which one is this? When I put like this. Start, what is it?
Langhans, giant cells.
So what can we do? Do you see caseated?
No.
So just tell me, non-caseated tuberculoid granuloma. Point. Okay? As I said, it's a small picture. These lymphocytes are not enough for you to see it is tuberculoid or not. Yes? Tuberculosis or not. You just tell me, non-caseated tuberculoid granuloma because you see multinucleated giant cells of Langhans type. Okay? Epithelioid granuloma, excuse me, because I see Langhans sometimes in sarcoidols also. Okay? I want you just, important for me for this year, that these pale aggregates, you tell me these are granulomas. These are epithelioid cells. These are multinucleated cells. Okay, this is important for me for this year. And there is no necrosis in the central part. Okay, all the pictures, all my questions will be concentrated on this because this is what I want from you now. Which cells?
What? Langhans.
Multinucleated giant cells of Langhans type.
Same Langhans.
Okay? Now,
Foreign
what
body.
is this?
Foreign body.
Foreign body. In foreign body, look at, you don't see
Irregular.
very much epithelium. Yes? It's just histiocytes. And as I said, it is ill-defined, and your diagnosis will come from this multinucleated giant cells of foreign type. Okay? You can see, as we studied in theory, foreign body can be organic or inorganic material. Inorganic, anything that comes from outside, or from the body pigments, like cysts also, okay? But organic, like parasites. Okay? And it can be inorganic, the sutures. You will see a lot in your practice. You send us, as I said, keloids or scar tissues and hypertrophic scars, and you want to know what's happening, and I will say only multinucleated giant cells with foreign type with sutures. So it's post-operative scar tissue that is hyper. Okay? So it's important. What is this?
Rheumatic.
Fibrinoid with this eosinophilic histiocytes, what do you call it? Aschoff nodules. Important. Where are located, boys? Where are located these Aschoff nodules? Myocardium. Remember, they cause mitral stenosis. Remember, what is this? What figure? Rheumatic fever. You will see fibrinoid necrosis with anti-Hoff cells, which are histiocytes with eosinophilic cytoplasm. Yes, and Aschoff nodule is granuloma. It's histiocytic granuloma. Okay? Someone asks you, what is Aschoff nodule? You tell me this is histiocytic granuloma. It is composed of central fibrinous necrosis with eosinophilic histiocytes, if you forget the name. Anti-Schott cells. They can be mono or multinucleated fused. I will say fibrinous necrosis, and I will say epithelioid histiocytes activated, and they can be now. They have a special nucleus. They are elongated sometimes, but the nucleus, it can be either caterpillar, like longitudinal, or it can be oval-eye. Okay? So they can be oval epithelioid-like, or they can be round with oval eye, but it is very characteristic the features of the nucleus. And of course, I will see eosinophilic cytoplasm. Okay? So this is rheumatic fever Ashok nodule. Number 1, histiocytic granuloma. Number 2, what is it? This is what one? This is first myocardium. Look at the fibrinoid, look at these eosinophilic cells, and look at the nucleus, how they are ribbon-like or oval-like. So this is Ashok nodule. Now, rheumatoid arthritis, I will see central, it is palisading. Remember this. Why? Because you will see in the central part this fibrinoid, and surrounding it will be palisading. Okay? This histiocytes with lymphocytes, and they are called, if you listen, hear the word necrobiotic, means in the central part you have fibrinoid necrosis. Okay? But for me, remember, this is called histiocytic granuloma palisading type. Remember the one epithelioid pseudotubercular separated. It is easy for you to study. Yeah? So when you say palisading, so something in the central will be, which is fibrinoid, surrounded with histiocytes and lymphocytes. Okay? Look at this palisading, how they are palisading to the central fibrinoid necrosis. And I can see them in the skin or in subcutaneous area near the joints. Look at how it is palisading. Yeah, remember. Now, foreign body we spoke. Yeah, it's easy. You catch them from multinucleated foreign body type cells.
Cholesterol,
Cholesterol, what do I see? This is foreign body. Yes? Foreign body is cholesterol. What I will see? Multinucleated giant cells of foreign body type. Plus, you know this now. Remember. Which cells? I will not say. Remember. Foam cells. Remember? Because I see cholesterol in macrophages, and macrophages are called foam cells. Okay? Once you see this is, you tell me, foreign body granuloma for cholesterol, I will see multinucleated giant cells, foreign body type plus foam cells. Okay, this is a picture, close. You see multinucleated, and these are bubbly cytoplasm, they are foam cells. This is suture material, that's what I said in hypertrophic scars. And finish. Now I will come to the theory, the last part. 5 minutes. Okay, the questions. The questions of the last part is the, I will ask today, okay? Don't tell me, because groups yesterday said, well, we don't know, etc. Repair and fibrosis. Number 1. What are the 2 mechanisms of repair? Regeneration and fibrosis. Question number 2. What is regeneration?
Replacement of the
Replacement with the same tissue. What are the tissues according to regeneration? Start. Labile. Stable.
Permanent.
Permanent. What's the difference? Labile always, like stem cells.
When necessary.
Stable sleeping, but they can wake up liver, and permanent, no, give me. Nervous, skeletal, and heart. Okay? This is very important question. What is regeneration? If the repair was all with regeneration, that was great. But that's something unfortunately impossible except in superficial wounds. Now, when I have deep wounds, I will have with it number 2, fibrosis. What does it mean, fibrosis?
replacement by
Replacement with fibrous tissue. What is the most important tissue that starts? Granulation tissue. Okay? Now, I will ask you the 2 questions. what are the differences between hypertrophic scar and keloid. First, you
Hypertrophic,
tell me they are
excess.
exaggerated scar formations. Yes? The
hypertrophic.
number one.
Hypertrophic is in the
Hypertrophic
wound.
collagen is
In the
1. The second one, keloid collagen
Out
is
of-
3. It is out,
Out of
the
the wound.
proportion. When do I see keloids? Give me.
Yeah. Huh?
Genetic predisposition, special locations like
Earlobes, face, and upper extremity.
Okay. Now, sclerosing, when I say in the scars, you will read sclerosing the scar tissue. What do you understand? It's fibroblast with hyaline degeneration in the collagen. Okay? You read hypertrophic scar, you already know hypertrophic because you see it in the area, but you want to be sure that there is no malignancy there, okay? They just write hypertrophic scar. Keloid, again, you suspect of malignancy, but they send it just keloid, which means it is hypertrophic, the hyperplastic, exaggerated form of a scar tissue. And the collagen, remember, all this big, it is collagen number 3. Okay, any questions? Now, I will send the questions written, yes, today, but these are what I have said. And now, I think both groups will come to me there now, because, not you group?
Yes, yes.
You group?
Yes.
You forgot? Now, I have explained this. Yes. Maybe if some students come from a group of the Hanush, I think, I will put the pictures quickly, yes? Because I haven't explained to them, and they may come. So it's good for you. I will not do presentations. I will put these pictures, and you will tell them what's the diagnosis. Yes? If they don't come, we will do presentations. Yes? And I will do tests. Don't be so. Okay? Everyone, the code will start. What is chronic inflammation? What is granuloma?
No, not for Tuesday.
It's already done.
You have done? Okay, the other ones. For the code, we'll start with this. Yes? And then I will continue. Okay, then you go after them. No, not to it. You will come. You will come with me. I will do the pictures again if they come. If they don't come, you will do your presentations. Yes? The first 2 hours you will be with us. I will take attendance. The third hour they will do test. Okay? Agree?